Welcome to the next episode of Mic'd Up with ChiroUp. This podcast is built to help you elevate your game as an evidence-based chiropractor. You know, each episode is designed to sharpen your clinical skills and really expand your thinking. And then, just this last year, introduce technologies that can help transform how you practice as a chiropractor. So today's episode. So what are we going to talk about today? Well, we're going to take a fresh look at orthopedic evaluation for benign paroxysmal positional vertigo. Don't try saying that 5 times fast. It will get confusing. It's going to be a small shift in your assessment strategy. However, it can really change your diagnosis, and I'll explain what I'm talking about when we get to that section. And then we're going to give you a quick spotlight on some new EHR functionality that's going to really prove why software innovation should be at the forefront of every modern chiropractic office. And then finally, we're going to take a deeper dive into joint play. I was just at the FTCA conference in Portland, Oregon, and I was listening to Brett Winchester speak on motion palpation. And this really goes back to where I started as a chiropractor. And I had a thought in my brain, and I want to dive into that using some research, a little bit of opinion, and really go through some experiential things that we've done as far as a chiropractor to really highlight one of the most fascinating aspects of what we do. It's really kind of a neat conversation that I hope you'll get a lot out of. And I think that once we can understand how to assess and treat joints through this lens of an elastic barrier, physiologic barrier, or anatomic limit, depending on how you determine how to manipulate, we can get down to the nuts and bolts of what is joint play and how do we use that as chiropractors to let us know what treatments we can do with a patient. So let's dive into this. First, I want to go through a little bit of evidence and a little bit of research. Now, this section I think is extremely important. Normally, we focus on sensitivity and specificity and those kind of things when we talk about orthopedic tests. However, this one is going to be a little different. And if you remember correctly, a couple of years back, we did a network analysis, and we found that the number one diagnosis that chiropractors using ChiroUp treated and got the best clinical results, meaning their patients got the most pain relief in the least amount of time, was BPPV. Now, this is one of those diagnoses that if you don't treat, you absolutely should. However, let me share with you some news. And, kind of here's what we know, is that when you're evaluating vertigo, and we suspect their dizziness is coming from some kind of pathology within the semicircular canals, we know that there are select positional tests that can really help highlight which plane or which canal that the problem is arising from, the semicircular canals. Personally, I have always used the Dix-Hallpike maneuver first. Now that's going to go at the ipsilateral posterior canal and the contralateral anterior canal when you're performing that maneuver. But then if I found that was negative, then I went to the supine and roll test, which evaluates the less likely source of BPPV, but it would be the horizontal canals. So that's the way I've always done it. And the reason is because posterior canal BPPV is the most common. Well, why not do the most common test? And that would be the Dix-Hallpike maneuver. However, what we have found is that a new paper came out, and I know you just read this because all of us evidence-based chiropractors always deep dive into the European archives of otorhinolaryngology, laryngology. Can't even say it. But this June just came out, and this really does affect us. So this one paper changes the way that I do my test. Not the way I perform it, but the order in which I perform them. So here's what I found, is that there is an order effect when performing diagnostic maneuvers during BPPV. So when you start to displace debris, which would happen in the Dix-Hallpike maneuver or happen in the supine roll test, is you're starting to move those the debris or the otoliths within the semicircular canals. So we really should consider which tests we do first. And in standardized protocols, we should actually start start with the supine and roll test because it will decrease the order effect. So it's not going to affect our Dix-Hallpike maneuver if we do this one first. However, if we do the Dix-Hallpike maneuver first, it will affect the supine and roll test. So if you want to read more about this, if you want to read the blogs and obviously watch the webinars, and of course go into the condition reference section on BPPV in ChiroUp, please do so. However, the end of the conversation with this paper says that if you are assessing for BPPV, make sure you do the supine roll test first and then do the Dix-Hallpike maneuver. I hope this helps. This is one of those things that may seem small. However, for those of you who evaluate BPPV, it is extremely important to know which canal you're dealing with, and that helps determine which maneuvers are going to help that patient get out of pain. So this may help a lot of patients. Next, let's dive into the EHR software. Now, I'm not going to focus a lot of time on this, but I think it's important to know just this year, we've released the Aloha integration. We've released the compensation calculator, which is essentially the best reporting I've ever seen in an EHR. We've released voice to chart. I mean, listen, this voice to chart, this functionality is not transcription. It's not just listening to a conversation and puking out a transcript. It's not having multiple clicks or using multiple softwares or web pages and inserting the text into your subjective note. This one piece of functionality has taken 18 months to perfect. This is absolutely revolutionary, really, in its UI, its UX, and compliance, all with the push of a button, something that's been very fun to use as a chiropractor. However, that's not what we're talking about today. In this podcast, we're going to talk about the editable subjective section. Now, some people who are using the EHR may be like, yeah, we got to have a way to edit what the patient are telling us on the kiosk. Not only are you going to be able to do that now, but you're also going to be able to edit the body picker with a click of a button, and it will show you which sections of the body the patient's experiencing symptoms. So from this section, you can actually edit their responses. Now, you can always edit this in the SOAP output. You can type in whatever you want. However, let me explain something to you in this podcast. I think this is a missing point that is extremely important, is that what we have allowed in this functionality is for you to edit the actual response within our canned responses, meaning are you doing better, worse, same, is different than you say I'm doing much better, I'm doing much worse, or it's doing somewhat better in the mornings. Because once you introduce that kind of variability into your subjective, you can't use that for research. So the reason we have some of those canned responses in there is that we're not playing a better subjective game. We're playing a different game. And when I say that is because we're going to be able to, in the near future, take all of the responses, all of the reporting, all of the billing, all the scheduling, and help our researchers as chiropractors help us make a better profession. And I know what you're thinking. Everybody says they're in it for something else. However, we are. We're not just building features to help you get by. We're not cutting corners to please shareholders. We're not answering to venture capitalists who don't understand our profession. They don't understand our purpose. Think about who owns your EHR. Are they in it for you, or are they in it for profit? We're at ChiroUp. We're chiropractors. We're building this for chiropractors. We're creating EHR powered by data, powered by outcomes and integrity to improve the next generation of chiropractors. This isn't just a software. This is the foundation of research that will change our profession. Every outcome, every patient survey, every data point helps us tell the real story of how we improve people's lives. So I'm going to get off my soapbox. That was the unintended pun, because in the EHR we actually don't say soap. It's SAOP, SAOP, which is the way we do our notes. That was funny to me, but it probably isn't funny to you if you don't use the EHR. But really, at the end of the day, how are we going to improve our notes? How are we going to improve the lives of patients? And of course, make it easier for us to practice. So I hope you guys are enjoying the editable subjective. I think that's something that's going to help all of us practice a little better. Now, for the reason most people listen to this podcast, let's talk about the clinical topic. Now, I don't want to jump into cavitation. I think that if you really want to go into, the cavitation, essentially the action associated with manipulation, the audible pop that accompanies high velocity, low amplitude thrust, check out, we have a ton of stuff on that. We have blogs, we have webinars, we have some cool stuff because, cavitation occurs when you have that rapid joint separation. It creates the gas cavity. That's what creates the tribonucleation and creates the pop within the synovial fluid. That's the stuff that we know happens. Modern cine MRI really shows how this pop, this bubble, this formation happens by separating joint surfaces. And if you want a deeper dive into that, check out our blogs. Go into chiroup.com. We have a research synopsis in that. And really, we're kind of getting into the story of refuting that classic Sandoz model from the 1970s and going more towards joint separation. However, that's not the topic. That's not what we're talking about today. We're going to shift our attention to not the manipulation, but we're going to shift it to the assessment side of manipulation. And I really want to focus on this one detail because it's intriguing. It's intriguing to me as a provider. However, when you start to dig into the mind of a new provider, which I did, and I'll give you some stories about, and then you also dig into the minds of a patient, this one piece we call joint play really has a big background, a big part of how we practice. So I think that let's talk about this. Let's go through how most providers like you and I rely on joint play assessment. Now, just as an acknowledgement, I do want to note or acknowledge there are many valid ways chiropractors assess where a joint may benefit from manipulation, both through static and dynamic evaluation. My goal is not to suggest that one approach is better than the other. I fully recognize that there are other ways of doing this, but my experience and my research is limited because of its amount to one specific method, which we're going to talk about, joint play. Now, what is joint play? Let's talk about that first. So joint play refers to that small, really just a passive, non-volitional movement between articular surfaces of a synovial joint. So you can't really do this by active range of motion. You're going essentially to a passive range of motion, and we're looking for this within a physiological range of motion. I mean, we're not dislocating joints. We're taking a joint to end range, and then we're seeing, hey, does it have a little bit more? And the joint's ability to glide or distract or spin or to slide, to do this within a normal range of motion and for it to feel springy is a good thing because the joint has available range of motion. However, when you take that to end range and it feels stuck or reduced or a hard end feel, then we as chiropractors, and I'm sure other professions use the term joint play, but I'm not familiar with that, we consider this a hypomobile joint. And now I'm thinking, okay, there's a reason, something's wrong with this joint, and now I need to restore motion to this joint, restore function to this joint through manipulation. So let's talk about this. So in the assessment, what are we actually doing during joint play? And what we think we're doing is that as an examiner, as a chiropractor, we go through the functional position and assess the quantity and the quality of this motion. So is there motion here? Is it reduced? Is it hypermobile? There are plenty of joints that are moving just fine or maybe even a little more than the other joints. And those are the things that we probably don't want to adjust. For those of you who just take a random approach like the flying sevens, well, you know what? Those people probably aren't listening to this podcast now that I think about it. But those are things that probably aren't in the evidence. It's already moving enough. Let's not try to get it to move more. It's kind of like manipulation of the shoulder and the jaw. While there may be clinical benefit, it's been really tough to find that in the research. And why wouldn't it? The glenohumeral joint and the TMJ, those are the most hypermobile joints in the body. So it doesn't seem like manipulation would be the best suited for that kind of joint. Now, going back on track. So when we are looking for joint play, what are we feeling for? Not only are we feeling for springiness, or not springiness, meaning a hard end feel, we're also looking for a pain response that occurs during that joint play. So when we get joint play and we get information from that, it really provides a framework. And really, when I think about this, do these joint surfaces move passively relative to the other? And it really is telling me is, can I achieve full range of motion about this joint? And this is really beyond what a patient can actively do, because it's not occurring with muscle contraction. This is happening passively. And now, if you have a different definition of what joint play is, hit me up. I'd love to hear what your definition of joint play is. Now, when we have restricted joint play, what should we do? And the purpose behind most chiropractors is to perform manipulation. And for the sake of the most amount of research, HVLA manipulation. So high velocity, low amplitude manipulation. So we can normalize or really restore joint play. And if we can do this, we know there's a lot of different things that can happen. And when we perform manipulation, we obviously will sometimes, hear a pop and a crack. But really what we're feeling for is, did we change the end field? Does this joint now have better, not only function, but usually it's going to not only hear some sound, we hear some music as we move joints. That's my favorite part of the day. But really at the very end of it, after we manipulate, do you go back and reassess? Because what we should feel is that now that joint has improved joint play. One of the things that I think is underappreciated in our profession is we palpate to learn where to adjust, but rarely do we go back and make sure that joint is now moving. And that's important for two reasons. The main reason is you and I need to know is it's a clinical sign. Did we do something? But also, when you go back and recheck, if a patient did not hear a pop, they think that manipulation didn't work. But what are you and I going for? We're going for improvement in range of motion. So even if you don't hear a pop, if you go back and recheck, it's showing the patient that while sometimes we do want to hear a pop, we want to hear those joints, cavitate. We're really looking for improved physiological range of motion. Now, the toughest conversation that you and I are going to have in the office is that what happens when you and I assess joint play, it's reduced. You go to manipulate and you don't get any cavitation. So I'm not going to have the conversation of, is the manipulation good or bad? Or did it work or did it not work? Doc, did it move? We're not going to have that conversation right now. However, let's have a conversation on this. What are the top 3 things that reduce joint range of motion or reduce joint play, but that joint's not going to cavitate? So let's talk about those things, because there's some good research, and I'm going to, of course, include some opinions in here. However, let's cover number 1 first. So what if you have capsular or ligamentous, I guess it could be either one, stiffness or any kind of fibrosis limiting that joint? So the ligaments are on the spine, really the ligaments around the facet joints. Think about this. If you get in a car accident, could you have capsular sprains? Could you have acute synovitis within that joint? Can you have facet irritation? Or even if that's chronic, could you have excessive collagen deposition if you have some chronic or repetitive stress to that joint? So if you have poor posture, if you do a repetitive stress, maybe for a sport, and that facet is inflamed, so that fluid in there is already expanding that joint, do you think HVLA manipulation is going to expand it even further and you're going to hear a pop? No. Think about if you have chronic inflammatory arthropathies like ankylosing spondylitis, psoriatic arthritis. Well, those may not affect the spine as much. And rheumatoid arthritis, very limited, usually in the upper cervical spine. However, these things can now show a joint that feels stiff because those facet joints and those spines are really stressed because of inflammation. However, you're not going to hear a pop or crack. Now, does this mean manipulation is a no-go? I would say no. I would say that if I have these things, and this is what I'm suspecting, I'm not going to not manipulate someone who has very little joint play and has just had a car accident, and obviously red flags are ruled out, imaging is ruled out. I think it's a relative contraindication because what I find, and now this is an opinion, is that I would probably, after the first time, like, you know what, that was probably a little painful. We're stretching joints that are injured. I would probably consider mobilization for the first visit or two, and then once it cools down, then dive back into HVLA to make sure that joint stays mobile while that tissue heals. Next, what happens when you feel reduced joint play and they have degenerative joint changes? You and I know that we can still manipulate those joints, but you and I also know that that joint doesn't feel the same as other joints. There's definitely reduction in glide and in gapping of those joints, and it definitely feels stiffer at end range. It almost feels like a hard end feel. It feels like blocked, and really one segment, if not multiple segments, feel like there's, for the lack of better words, concrete in those joints. And I'm all for grade 5 manipulation, but there is an inverse relationship to DJD and successful pain resolution and improvement in range of motion with manipulation. So we can't avoid the research, because the simple fact is, if there is enough degeneration, you're not going to achieve more range of motion or a cavitation with that joint, because it literally can't be pulled apart. So after the first couple of tries with no success, then of course I'm going to move to a method that yields better results. Now, once again, I am not insinuating that joints that have manipulation or joints that have degeneration are not candidates for manipulation. I'm not saying that at all. However, if a joint has enough arthritis, then unfortunately that HVLA is not going to be able to break through the stiffness due to that calcification and achieve a meaningful result. The last, and I think probably the most important, is that if I have muscle guarding due to pain, due to injury, maybe it's neurologic, if we have any kind of reflexive paraspinal activity for any number of reasons, that will also limit joint play. So that's the last one that I want to cover. And now this would be also an opinion. I think this is probably the most common. And I think that this is the most reasonable explanation for joint dysfunctions, at least at the beginning. And I want to cover two things, because these two things, while they are a little geekish as far as what we do, it's important to just kind of get that refresher. I've been out for 15 years. I forgot these things until I dive into ChatGPT or dive into ChiroUp. I forget, most of the things. I mean, dementia setting in earlier. That's why Dr. B's not here. He forgot the podcast was even going on. I'm kidding, Tim. He's probably listening to this now. This number 3 here is I think the two things that we're probably overcoming. The first one, the muscle spindles. The second one is the Golgi tendon organs. And I'm sure there's probably someone who's going to argue with me. However, when we have muscles that are really tight around a joint, what does manipulation do? Well, manipulation, let's talk about the muscle spindles first, is they initially fire when I go to create that thrust. So you're briefly going to excite those muscles surrounding the joint, and then almost immediately afterward, they're going to enter that short period of reduced sensitivity. They're going to decrease that alpha motor neuron activity. And what are you going to see? What is the patient going to feel? That muscle is going to have that temporary relaxation. It's going to feel better. And then, of course, when we go to recheck, the range of motion is going to improve. Now, that combined with the Golgi tendon organs, these things sense tension. They sense that tension at the muscle tendon junction. And when you thrust, when you briefly increase that tension, they're going to activate. And I think it's the A beta fibers, I believe, the A alpha afferents are going to trigger that inhibitory reflex. And now we're going to once again get that overactive muscle to relax. And some research has reset its tone. So rapid, muscle activation, and then it goes back to normal. So, this is the things that I think happen. And the reason I think this happens is because of the short-term, very fast results that we get. When I manipulate a patient, they feel better immediately. In fact, most patients, when they leave my office, hopefully all my patients, but most patients, they walk out feeling better. So it has to be something quick, something that is happening within, in this case, milliseconds. But the manipulation, the manual therapy, the exercise, muscle guarding, and muscle splinting would make sense of why these things reduce joint play the most. And this is the reason why we have so many patients who love coming to see us. And I think that this is the easiest, this is the short-term effect that we have. Could it be the other ones? Yes, absolutely. But I think that the takeaway message from this podcast has to be, kind of two things. First, which we just covered, if it doesn't pop, that doesn't mean you didn't have any effect. So if you have reduced joint play, you go to manipulate it, you don't hear a pop, don't feel like it didn't work. Because manipulation can still produce that neurophysiological, that mechanical response, that improvement in joint range of motion. So always recheck. It tells you and it tells the patient information. The second part of this is, documenting hypomobility and assessing for joint play is how we do what we do. Now, I'm going to get an email or probably 10, and it's going to be the same couple of papers. As the intra-examiner reliability of motion palpation has been questioned, that there's such high variability between examiners, and I fully expect people to cite some papers and send those to me. I get it. I understand, and I take that into consideration. And you are not wrong, but no more wrong than I am. Because motion palpation by itself, meaning if you just assess joint play and that's it, that's all you do, and you manipulate everyone that has restricted range of motion, you and I are not friends. Because that's not what the evidence says to do. Just like you can't do one orthopedic test and determine the diagnosis. We have to take that as one component in a full clinical assessment. Take into consideration the patient history. Take into consideration the orthopedic testing, the neurologic testing, the functional movement evaluation, then palpation and visual observation. Those are the things that are going to help us determine, is that joint play truly just muscle, ligament, joint, and can I manipulate this patient? Because our goal with manipulation is to overcome that stiffness and resistance and to restore range of motion. And if we can do that, not only are we going to help the patient, but we're really going to help hone in our skills on who to manipulate and who not to manipulate. And I think this is one of the biggest contrasts that I see in our profession, the people that just randomly manipulate everything and the people that really take all those things into consideration and determine who is manipulatable and who is not. So in closing, I hope this helps. I had a lot of fun at the FTCA seminar. I really think that joining groups or being around people who think the same way you think is refreshing. But even more refreshing is when they, as far as the speaker, the people around you, can highlight a gap in your knowledge and make you take a deeper dive to make sure you understand why you're doing what you're doing. In closing, when we talked about the BPPV, please take that into consideration with the next patient and do the supine roll test first. When it comes to choosing your EHR, I know one great company out there that shares the same goals as you and I do. Make sure you check out the ChiroUp EHR. And then finally, choose your assessment wisely before manipulation. Manipulation is the safest, non-surgical, non-pharmacological treatment we can do for patients when they don't have red flags and when it's not traumatic. Manipulation is the tip top of the pyramid in conservative medicine when applied appropriately. When it's not applied appropriately, it's cavalier. So take a quick glance, a cursory overview of how you do manipulation, and more importantly, how you determine where to manipulate. And I hope this podcast helps. If you have any questions or concerns, Brandon at chiroup.com. Thanks for listening.